Hi students, I'm Dr. Sakshi Arora, your OBGYN faculty at Marrow, and today I am here specially for all the FMG bachas. In the Marrow app for the FMG students, the previous year FMG questions are also there. So in this session, I'm going to tell you how to use this feature of the Marrow app, and also I am going to take up a few PYQs with you, and towards the end of the session I'm going to tell you what are the most high yielding topics in obs and gynae for FMGE, right? So in the beginning, first let's see how are you going to get the FMG papers? Where are you going to look for the previous year FMG papers? Now for that, the first thing what you have to do is you have to be sure that in your course you have selected FMGE edition 6. So whether you are open to accessing Marrow through mobile or through your iPads, please on the top left hand side click and check what course you have selected. So you should select the course FMGE edition 6, then only you will be able to access the PYQs of FMGE. Once you've done that, go to this QBank section. Now in the QBank section, at the end, at the bottommost place, you are going to find previous year question papers. So click on the previous year question papers. And here you can see the previous year question papers have not only been arranged year-wise, they have also been arranged subject-wise for you, right? So whichever subjects previous year questions you want to attempt, you can start attempting. Now, since I want to discuss with you PYQs of OBGYN, I am going to use this index over here. In the index, I'm going to select obs and gynae. And I have the obs and gynae previous year questions in front of me. So let us see FMGE June 2022. Let's do a few questions from FMGE June 2022 paper. As far as your January 2023 questions are concerned, they are in the form of a GT, and that grand test is live as of now, right? So you can attempt January 2023 paper in the form of a grand test, right? In the app, you have got PYQs of June 2022 session. Then you have December 2021 session, June 2021 session, December 2020 and August 2020 session, right? So let's see a few questions from FMG June 2022 in OBGYN. Now, as you can see, there were 35 questions which were asked in June 2022. So let's see a few of them. Okay, so over here the question is, preconceptional use of dash leads to reduced incidence of neural tube defects. I'm sure all of you know the answer. So what is that vitamin which you prescribe to a pregnant female so that the chances of neural tube defects are decreased? It's a very easy one. That is folic acid. So you are going to click on folic acid. And once you click on folic acid, if your answer is correct, there will be a green mark there. And if you give an incorrect answer, there is going to be a red mark there, right? Now, over here, you are also going to get explanation and the correct answer for that particular question. So as you can see over here, they have given, the explanation tells you prophylactic iron and folic acid supplementation. So they are giving you details of the Anemia Mukt Bharat program. Clear to all of you? Yes. Now, let us discuss folic acid supplementation. Let me discuss it with you. This is very important, folic acid supplementation. Now, folic acid supplementation, it is done in all pregnant females and it has to be done in the preconception period. So, if a pregnant female doesn't have any history of neural tube defect, then the dose of folic acid which you have to give is 400 micrograms. 400 micrograms, or you can say 0.4 milligrams. This should be started 1 month before conception. 1 month before conception. And it has to be continued till, 3 months after conception. 3 months after conception, right? Now, if a female has previous history of neural tube defects, female has previous history of neural tube defects, in that case, the dose of folic acid which you have to give is 4 milligrams. You have to start this at least 3 months before conception. At least 3 months before conception. Please understand that we are gynecologists, we are not astrologers, right? So I cannot tell a pregnant female that 3 months from now you are going to become pregnant, right? So although theoretically we say that folic acid in a female with previous history of neural tube defects should be started 3 months before conception, but a better answer would be as soon as she plans pregnancy. As soon as she plans pregnancy, I have to tell her to start taking 4 milligrams of folic acid. And again, it should be continued till 3 months after conception. It should be continued till 3 months after conception. Right? Now, the other very important thing is they may ask you what is the dose of folic acid to prevent neural tube defect. Now, if they ask you the dose of folic acid to prevent neural tube defect, you know it is 400 micrograms. But read your questions very carefully. If they ask you what is the dose of folic acid to prevent the recurrence of neural tube defect. So, if the question is to prevent the recurrence of neural tube defect, then in that case, the dose has to be 4 milligrams. Now, if they ask you what is the dose of folic acid which you should give in a diabetic pregnant female. Now, since all of us know that in a diabetic pregnant female, there are increased chances of congenital malformation. So we think, and the congenital malformations which are most commonly they're seen in a diabetic female's baby are cardiovascular malformations followed by neural tube defect malformations. So we think that because neural tube defects are common in babies of diabetic mothers, so we should give them a higher dose of folic acid, and that is 4 milligrams. But that is incorrect. In a diabetic pregnant female, the dose of folic acid is again 400 microgram unless and until your question says that the diabetic pregnant female has previous history of neural tube defect. Obviously, if there is previous history of neural tube defect, then the dose which you have to give is 4 milligrams. 1. Number 2, if they ask you what is the RDA of folic acid in pregnancy, RDA of folic acid in pregnancy. What do you understand by this? RDA is routine daily allowance of folic acid in pregnancy. Then your answer is 500 micrograms. Number 3, if they ask you what is the dose of folic acid in a female in a pregnant female on anti-epileptic drugs. On anti-epileptic drugs. Now again, this is an area where there are lots of controversies because lots of places this answer is given incorrectly. What I am telling you is strictly from the 26th edition of Williams. You are going to answer this. Now before a female conceives, if she is on anti-epileptic drugs, the dose which you are going to give her will be 400 micrograms per day, right? But as soon as she conceives, when she has conceived, you are going to change the dose to 4 milligrams per day. Is that clear to you? So if your question is dose of folic acid in a pregnant female on anti-epileptic drugs, pregnant female on anti-epileptic drugs, your answer is going to be 4 milligrams per day, right? Now, what is the dose of folic acid to treat megaloblastic anemia? So now we want to know the dose of folic acid to treat megaloblastic anemia. The dose of folic acid to treat megaloblastic anemia is 1 milligrams per day. And what is the dose of folic acid in a patient with sickle cell anemia? So if a pregnant female has sickle cell anemia, then what dose of folic acid are you going to give her? Then it is 5 milligrams per day, right? And what is the dose of folic acid which is present in IFA pill, which is recommended by the Anemia Mukt Bharat program? So in the IFA pill, you have 60 milligrams of iron plus 500 micrograms of folic acid. Why 500 micrograms of folic acid? Because that is the RDA of folic acid in pregnancy. Clear to all of you? Yes. Now let's see the other question. I'm going to the next question. Next question is identify the fistula below. Now in this image, what can you see? In this image, you are seeing over here this tube-like structure. The tube-like structure which you can see in the image is the ureter, right? Then you are seeing the bladder, and just behind the bladder you can see a vagina. And this fistula is connecting the bladder to the vagina. So any fistula which is connecting the bladder to the vagina is vesicovaginal fistula, right? So this over here is vesicovaginal fistula. Clear to all of you? Yes. Now as you can see over here, they have given you details about vesicovaginal fistula, that what complaint patient is going to come to you with a vesicovaginal fistula. You tell me. What do you think a patient of vesicovaginal fistula is going to come to you with? How is she going to present to you? So over here, I have a bladder. I'm drawing the bladder for you. So this over here is the bladder, right? This over here is ureter, and this is vagina. Now, if there is a fistula which connects ureter to vagina, that is ureterovaginal fistula. If there is a fistula connecting bladder to vagina, that is vesicovaginal fistula. And if there is a fistula which is connecting urethra to vagina, that is ureterovaginal fistula. Now, in all these three cases, the complaint of the patient is going to tell you which type of fistula it is. So, from the history itself, you will come to know which fistula we are talking about. So, imagine if a female has ureterovaginal fistula. So, first I am talking about ureterovaginal fistula. Ureterovaginal fistula means one of the ureter is connected to vagina via fistula. So whatever urine is coming through this ureter via this fistula, it is going to come out in the vagina, right? So this patient is going to say that she has constant dribbling of urine from her vagina. Constant dribbling of urine from vagina, right? Agreed? But this ureter is absolutely normal, and whatever urine this ureter is bringing, it is going to come in the bladder, right? And obviously a female is going to have only one fistula. Either it is going to be ureterovaginal or vesicovaginal, right? So her bladder is absolutely normal in case of ureterovaginal fistula. The problem is that one of the ureters is connected to vagina, right? So the other ureter, which is absolutely normal, is bringing urine to the bladder. So bladder is also getting full. So this patient, although she's constantly having dribbling from her vagina, but because her bladder is also getting full, she will also have an urge to urinate, right? So there will be normal urination as well. She will have the urge to urinate. So if your patient complains that there is constant dribbling of urine from vagina, plus there is urge to urinate, in other words, normal urination also present, then it means we are dealing with ureterovaginal fistula. Right? On the other hand, if it is a case of vesicovaginal fistula. Now, if it is a vesicovaginal fistula, that means ureters are not connected to vagina. So these ureters, both the ureters, left and right ureter, are going to bring the urine to the bladder. And the problem is that this bladder is connected to vagina, right? So obviously this patient again is going to come to me with complaint of constant dribbling of urine from her vagina. So this was one. Now the second complaint in the second case will also be constant dribbling of urine from vagina. Clear? But now tell me, because her bladder is connected to vagina, will the bladder ever be full? No. So if the bladder will never be full, will she ever have the urge to urinate? No. In other words, normal urination will be absent, right? So plus there is no urge to urinate, right? So normal urination absent. So if you see that in your question they are saying that there is constant dribbling of urine from her vagina and no urge to urinate, it means they are talking about vesicovaginal fistula, which in short is called as VVF, right? Then comes the third kind of fistula. The third kind of fistula is ureterovaginal fistula. Now, please remember that in urethra, urine is not constantly present. Urethra normally is empty. Urethra gets urine only at the time of urination. So, if urethra normally is empty, so if there is a fistula which is connecting urethra to vagina, patient will not have any constant dribbling of urine because urethra normally is empty. Now, what will the patient say? Patient will say, doctor, I don't have any constant dribbling of urine from my vagina. But when I sit for urination, urine comes out from normal places as well as from my vagina. Yes? Okay. So, the third kind of complaint is there is no constant dribbling of urine. There is no constant dribbling of urine from vagina, but when patient sits for urination, then urine comes out from vagina plus urethra, right? That is what is the complaint in ureterovaginal fistula. Clear to all of you, right? So let us see what is written in your explanation. In explanation, it is written that ureterovaginal fistula connects ureter and vagina. Ureterovaginal fistula connects urethra and vagina. Vesicovaginal fistula usually presents with constant dribbling of urine from vagina. Excoriation in the groin region. Obviously, if there is constant leakage of urine, there will be excoriation in the groin region. There will be history of pelvic surgery, vaginal delivery or prolonged labor. Please remember, in developing countries like India, the most common cause of VVF is obstructed labor. In developed countries, the most common cause of VVF is any gynae surgery which you would have performed, right? Hysterectomies. But in India, the most common cause is obstructed labor. And at times, amenorrhea may be present, right? Now, they have also given you what happens in case of a methylene blue 3 swab test, right? So, methylene blue 3 swab test, all of you are so fond of that. So they have also given you that if you do a methylene blue 3 swab test, that means you have put 3 swabs in vagina, the uppermost one roughly corresponding to the level of uretrovaginal fistula, middle one corresponding to the level of vesicovaginal fistula, and a lower one corresponding to the level of urethrovaginal fistula. And then with the help of Foley's catheter, we put methylene blue dye inside the bladder. Now, if there is a vesicovaginal fistula, the urine which is going to come in the bladder is going to be blue in color because the dye is put in bladder. Now, this blue color dye via the fistula is going to go and wet the middle cotton swab blue, right? Obviously, when this blue colored dye and urine together is falling, it is also going to color the lowermost cotton swab blue. But the significance of lowermost cotton swab blue is not over here. The significance is that the middle cotton swab turned blue. The moment I see that the middle cotton swab is wet and it is blue in color, I come to know that it is a vesicovaginal fistula. But remember, the investigation of choice for vesicovaginal fistula is not methylene blue 3 swab test, it is cystoscopy. With the help of cystoscopy, you can not only come to know about the exact size, about the exact number, you can come to know about the exact location of the fistula. That is why that is the investigation of choice. Clear? Let's go to the next question. When does secondary postpartum hemorrhage develop? So all of you know that primary is within 24 hours of delivery and secondary is after 24 hours and up till 12 weeks of delivery. So 24 hours to 12 weeks after delivery is secondary PPH. What is the most common cause of primary PPH? The most common cause of primary PPH is atonic PPH. And what is the most common cause of secondary PPH? The most common cause of secondary PPH is retained tissue. In other words, retained placental tissue. So the same explanations are given over here. Primary PPH, it occurs within 24 hours of childbirth and most common cause is atonic PPH. Secondary PPH occurs after 24 hours and up till 12 weeks postpartum. Most common cause is retained placenta. Also, they have given you the causes of PPH. All of you know that it is the 4 T's which are responsible for PPH. Number 1 T is tonicity, that is atonic PPH. Number 2 is trauma. Third T stands for thrombin, that is in all the coagulative disorders which may happen. For example, DIC. And fourth T is for tissue, that is retained placental tissue, right? So next question, identify the sign that is seen during 8 weeks of pregnancy resulting in dusky blue color of vagina. You can see that the arrow is pointing towards the dusky blue color and all of you know that is Chadwick's sign. And what is the other name for Chadwick's sign? The other name for Chadwick's sign is Jack-Mayer's sign, right? Signs in pregnancy are very, very important. The earliest sign to become positive in pregnancy is Goodell sign. Goodell sign means softening of the cervix and this is seen by 6th week. Then you can get the other signs like Palmer's sign. Palmer's sign are the regular rhythmic contractions which you are getting in the uterus. Then you can get Chadwick sign or Jack-Mayer's sign, that is the dusky blue color which you get of the vagina and vestibule. Osiander sign, that means the pulsations which you are getting in the lateral fornix of the vagina, right? Then you can get Piscasek sign. Piscasek sign means that there is asymmetrical enlargement of the uterus in early pregnancy. And all these signs which I told you just now, all of them, they become positive around 8 weeks. Then one more sign which you have to remember is Hagar's sign. Very, very important. Hagar's sign is when you are doing a bimanual palpation. Bimanual palpation means your one hand is behind the uterus perabdominally and the other hand is inside vagina. When you do a bimanual palpation, both the hands' fingers, they appear to meet or touch each other. Why do you get this Hagar sign positive in pregnancy? This is because the cervix and the isthmus, they become very soft in pregnancy, number one. And the entire product of conception is in the upper part of the uterus. So lower part of the uterus is empty. Now the lower part of the uterus, which is the isthmus, which is the cervix, is empty and soft. So when I will put my one finger behind the uterus parabdominally and other finger inside the vagina, my both hands fingers will seem as if they are touching each other, right? So that is Hagar sign. Please remember, Hagar sign becomes positive between 6 to 10 weeks. So Goodell sign becomes positive at 6 weeks. Hagar sign between 6 to 10 weeks, and rest all the signs they become positive by 8 weeks of pregnancy, right? So I think this is a very easy paper which came, and especially see in obs and gynae, if your concepts are clear and if you have done obs and gynae properly, but I can assure you that out of the 35 questions which come in your exam, you will easily be able to answer 32 questions. Right? But for that, you will have to make your basics strong. You will have to understand OBGY rather than mugging up OBGY, right? So this was your FMG June 2022. Let us see what type of questions came in FMG December 2021. So 20 MCQs came from OBGY in FMG December 2021 session. Let's solve them. The usage of the device given in the picture. So what do you see over here? You see that this is a cannula, which is a plastic cannula. And can you see these triangular openings at the proximal end? I'm sure all of you remember this cannula. What is this cannula? This is Carman's cannula. And when do you use Carman's cannula? It is used for abortions, and this is used for menstrual regulation or aspiration, in other words, suction and evacuation. In the video on abortions, I have told you various methods for doing MTP in first and second trimester, and there I have told you that for first trimester abortions between 7 to 12 weeks, the best method is suction evacuation. Right? How do you do a suction evacuation? You use this Carman's cannula, which is connected to a suction machine, and with the help of this cannula, you do a suction evacuation. Right? Now, remember that what size of Carman's cannula are you going to use? You are going to use that size of Carman's cannula which corresponds to the week of gestation. So for example, if your patient is 10 weeks pregnant, then you are going to use a 10 number Carman's cannula. The other thing which I want all of you to understand, whenever we say suction evacuation using Carman's cannula, although it is the best method for doing MTP up till 12 weeks, but then it can be done up till 16 weeks, right? So it is the best method to do MTP between 7 to 12 weeks, but suction evacuation using Carman's cannula can be done up till 16 weeks. Number one thing. Number two, in rural areas where electricity is not available, in those places, instead of using this Carman's cannula with the help of a suction machine, what we do is we use manual vacuum aspiration syringe, MVA syringe, manual vacuum aspiration syringe, right? Now, when you are going to look at your videos, in the videos, I have shown you this syringe, and the typical thing about this syringe is that this syringe has got two pinch valves. So there are two valves-like structures which are present in this syringe. So whenever you see a plastic syringe with two valves, that means it's an MVA syringe, right? Now this MVA syringe, there are few questions which they ask you on MVA syringe. See, just now I told you suction evacuation using Carman's cannula can be done up till 16 weeks, right? But if you are using MVA syringe can be used maximum up till 12 weeks, number one. Number 2 point, this is a 60 ml syringe. So next question they ask you this, that what is the capacity of this syringe? Third question which they ask you is, what is the pressure which is generated by this syringe? So the pressure which is generated by this syringe is 600 millimeters of mercury. If 600 is not given, then 660 millimeters of mercury, right? That is the pressure which is generated by MVA syringe. Clear to all of you? Okay, let's look at the next question. So over here also they have given you an explanation where they have told you that how you are going to use the Karman's cannula for suction evacuation. While performing the ultrasound assessment of a woman at 28 weeks of gestation, you note her amniotic fluid index to be 12.8. When does this parameter reach its maximum value in a normal pregnancy? Now, in other words, they are simply asking you when is the amniotic fluid maximum. Amniotic fluid is maximum at 34 weeks of pregnancy. Repeatedly in the app, I have been telling you that you don't have to get confused by this answer. Amniotic fluid is maximum at 34 weeks of pregnancy. If 34 weeks of pregnancy is not given and a range is given, then the range is 32 to 34 weeks. But if 32 and 34 both are given in the options, like in your exam, both were given in the options, then the answer which you have to choose is 34 weeks, right? So over here also they have told you that AFI, that is amniotic fluid index, or amniotic fluid is maximum at 34 weeks and the range is 32 to 34 weeks. Clear to all of you? Yes. What are the major contributors of amniotic fluid? So in first trimester, the major contributor of amniotic fluid is maternal plasma. So amniotic fluid is a transudation from maternal plasma. Between 12 to 20 weeks, the major contributor is fetal skin, and beyond 20 weeks, the major contributor is fetal urine. Overall, the major contributor is fetal urine. Next question. A woman presented in her 8th week of pregnancy seeking MTP. The appropriate dosage of misoprostol administered by mucosal route would be. So this is a question on medical abortion. And at 8 weeks, the dose of misoprost which you have to use is 800 micrograms. Now, I have told you this in the app also, that how do we go about with medical abortion. This over here is a direct screenshot from the Government of India guidelines for medical abortion. Now, please remember that Government of India recommends that medical abortion has to be done up till 7 weeks. So, in our national guidelines, they recommend that you should do medical abortion up till 7 weeks. But WHO says that medical abortion can be done up till 9 weeks also. That is why in clinical practice, you will see that medical abortion is being done up till 9 weeks as well, right? Now, whether you are doing medical abortion up till 7 weeks or when you are doing between 7 to 9 weeks on day 1, in both these cases, you give mifepristone 200 mg tablet, 1 tablet orally, right? Then you wait for 24 to 48 hours and then on day 3, you have to give misoprost. If you are doing medical abortion up till 7 weeks, the dose of misoprost which you have to give is 400 micrograms, right? But if you are doing medical abortion between 7 to 9 weeks, then it is 800 micrograms. Clear? Then in both these cases, you are going to tell the patient that she has to come back to you on day 15. Why are you calling her back on day 15? To check for the completeness of the process. Now, a very confusing point which all of you read and then you constantly ask me on my Instagram, on my Telegram, that ma'am, in medical abortion, is ultrasound necessary? Please remember, Government of India says that for medical abortion, ultrasound is not necessary at any point of time, right? Only, when you are beginning the process of medical abortion, and if you are suspecting ectopic pregnancy, how are you going to suspect ectopic pregnancy? If your patient is saying she is having abdominal pain, right? Or if she's saying she's having pelvic pressure, then I suspect ectopic pregnancy. Then in that case, I may do ultrasound. But in all females who are coming to me with medical abortion, before giving her mifepristone, I am not going to do an ultrasound. Similarly, when I'm calling her on day 15, to check the process, that to check whether the process is complete or not, I am not going to do an ultrasound. How will I then know that the process is complete or not? I will know because if female is saying that she had bleeding, but now the bleeding has stopped. If the bleeding has stopped, if internal os is closed, I'm sure the process is complete and I don't need to get an ultrasound done. Only if I am unsure that the process might not be complete, there may be some POC in the uterus, then in that case, I'm going to get an ultrasound done. Is that clear to all of you? The other thing which I want you to remember is that if your question says, these are new type of questions which might be asked. If your question says that you have given her misoprost and within half an hour of taking misoprost, your patient vomits. Now what are you going to do? In that case, you have to repeat the dose of misoprost only if she is vomiting within half an hour of taking misoprost tablet. Clear to all of you? Okay, let's go to the next question. A 24-year-old primary with 3 months of amenorrhea undergoes ultrasound. The ultrasound is suggestive of. Now, what is it appearing to you? Isn't it appearing as if there are snowflakes in the uterus? This is snowstorm appearance which you get in case of Hydatidiform mole. One of the most important IBQs which you have to remember is that of snowstorm appearance on ultrasound. Whenever you are getting snowstorm appearance of ultrasound, it is a case of Hydatidiform mole, right? Now you're going to tell me, snowstorm appearance is seen in case of complete mole or partial mole. Please remember, snowstorm appearance is seen in case of complete mole. What is the other name for complete mole? Hydatidiform mole or vesicular mole, right? What is the karyotype of a complete mole? A complete mole is diploid and the most common karyotype is 46XX. Clear? Right? Okay. So I think this was also pretty easy. Okay, so coming to FMG June 2021 questions. Here there are 24 MCQs which have been asked in your exam. And as you can see, 24 is again quite a lot number. See, OBGY is a very, very important subject for all of you. Many questions are asked from OBGY and it's a very scoring subject also. So let's see a few questions. A mother brought her 16-year-old daughter to the hospital with complaint of primary amenorrhea. On evaluation, axillary and pubic hair were present and other sexual characteristics were normal. Other secondary sexual characteristics means breast was normal. LH and FSH levels are normal. Ultrasound showed absence of uterus. What is the most likely diagnosis? Now, the keywords over here are primary amenorrhea, axillary hair, pubic hair normal, breast normal, LH and FSH normal. That means it's a case of Mullerian agenesis or MRKH syndrome, right? So let me tell you, how are you going to approach a patient whenever a patient comes to you with primary amenorrhea? Now, when a patient comes to you with primary amenorrhea, the first thing which you have to see is whether secondary sexual characteristics are absent or whether secondary sexual characteristics are present. Now, if secondary sexual characteristics are absent, so if secondary sexual, first let me tell you secondary sexual characteristics present. Now, if secondary sexual characteristics are present, then in that case, what you have to see is whether uterus is present or whether uterus is absent. So, if uterus is present and secondary sexual characteristics are present, then your diagnosis is cryptomenorrhea. Cryptomenorrhea. What do you understand by cryptomenorrhea? Cryptomenorrhea means hidden menstruation, and it is seen in case of imperforate hymen. In a patient of imperforate hymen, the only problem is that there is no opening in the hymen. Although she is menstruating, but menstrual blood cannot come out, right? So because her ovaries are normal, so estrogen will be normal. And because estrogen is normal, breast development will be normal, right? Her pubic hair and axillary hair will be normal. Everything will be normal. What about FSH, LH levels? FSH and LH levels will also be normal because her hypothalamus is normal, her pituitary is normal, her ovary is normal. So everything will be normal in her. Such a female comes to you with complaint of cyclical pain in abdomen. So in history, typically patient is going to say that every month she has pain in abdomen as if she is about to menstruate. But then there is no menstruation, right? So in this case, when you do a local examination, you are going to see a blue bulging hymen, right? And when you will do a per rectal examination, now you're going to say that, ma'am, why a per rectal examination? This is because in virgin females, we never do a per vaginal examination. If I want to see whether uterus is present or not, whether uterus is bulky or whether uterus is normal in size or small in size, I will have to do a per rectal examination. What do you expect in a case of cryptomenorrhea? You expect the blood to be collected inside the uterus, right? And that is why on per rectal examination, there will be bulky uterus. This bulky uterus is because of collection of blood inside the uterus, which is called as hematometra. So much so, sometimes the uterus is so enlarged that on per abdominal examination also you might be able to feel the uterus, right? Now comes the second side. Suppose if your question says uterus is absent but secondary sexual characteristics are normal. First of all, I want to tell you that whenever your question is saying secondary sexual characteristic, they mean breast development, right? So secondary sexual characteristic present means breast present. Secondary sexual characteristic absent means breast absent. Now, if uterus is absent, then you should have two differential diagnoses in your mind. One is Mullerian agenesis. Mullerian agenesis is also called as MRKH syndrome. That is Mayer-Rokitansky-Kuster-Hauser syndrome. And the other one is androgen insensitivity syndrome. Androgen insensitivity syndrome. Now, in case of Mullerian agenesis, the chromosome number is 46XX. Androgen insensitivity is 46XY. So, actually they are males, but they are insensitive to androgen. That's one difference. Another thing, in case of Mullerian agenesis, breast development is present. In Mullerian agenesis, what is the problem? In Mullerian agenesis, the problem is that Mullerian ducts are absent. So because Mullerian duct is absent, uterus is absent, cervix is absent, upper part of vagina is absent, fallopian tube is absent, right? But then ovaries are normal. Why are ovaries normal? Ovaries are normal because ovaries develop from genital ridge. They have nothing to do with Mullerian duct. Now, because ovaries are normal, so estrogen normal. Estrogen normal, so breast development normal, right? So, their breast development will be normal. And because they will have normal androgens also, that is why pubic hair and axillary hair will be normal. But what happens in androgen insensitivity syndrome? In androgen insensitivity syndrome, gonads are testes, and the problem is that these males are insensitive to androgens. Right? And please remember, whether it's a female or whether it's a male, for development of pubic hair and axillary hair, The hormone which is needed is androgens, right? So in this patient, in an androgen insensitivity patient, because they are insensitive to testosterone, the entire testosterone with the help of enzyme aromatase gets converted into estrogen. And that estrogen leads to breast development. They are insensitive to testosterone. They're not insensitive to estrogen, right? So breast development is present. But will pubic hair and axillary hair be present? No, because they are insensitive to androgens. In other words, insensitive to testosterone, right? So pubic hair and axillary hair will be absent. Have you understood? Yes. Next difference between them. Next difference between them is the gonads. In Mullerian agenesis, what is the gonad? In Mullerian agenesis, the gonad is ovary. In androgen insensitivity syndrome, the gonad is testes. Now, in case of Mullerian agenesis, what will happen to FSH and LH values? FSH and LH values. See, ovary is normal, hypothalamus is normal, pituitary is normal. So, LH will be normal, FSH will be normal, right? What happens to FSH and LH values in androgen insensitivity syndrome? In case of androgen insensitivity syndrome, see, I'm not going into the details, right? Because if I go into the details, it's a very long detail, and I want all of you to check out this chapter on, or this video on the Marrow app, where I have explained to you that what happens to FSH and LH values in androgen insensitivity syndrome. As of now, if you want to mug up, if you want to remember, if you want a trick that how you should remember that what happens to LH and FSH values in androgen insensitivity syndrome, remember, in androgen insensitivity syndrome, the levels of LH and FSH are similar to what they are in PCOS. So what happens in PCOS? In PCOS, FSH is normal, LH is increased, right? Similarly, in androgen insensitivity syndrome, FSH values are normal and LH values are increased, right? What about testosterone levels? Testosterone levels in Mullerian agenesis will be normal and they will correspond to the normal level of a female androgen, right? What is the normal level of androgen in females? It will correspond to that. But when we talk about testosterone levels in androgen insensitivity syndrome, actually they have testes. Testes will produce much more higher levels of testosterone in comparison to ovaries. So in androgen insensitivity syndrome, because actually they are males, so the levels of testosterone will be corresponding to male levels. In other words, they will be very high, right? In which condition are you going to get associated renal problems? So associated renal problems you are going to get in case of MRKH, in case of Mullerian agenesis. This is because Mullerian duct not only leads to development of female reproductive tract, but also to the parts of urinary system, right? So associated renal problems will be seen in Mullerian agenesis. They will be absent in case of androgen insensitivity syndrome. Is this clear to all of you? Yes. So now if I ask you, what is the investigation of choice to differentiate between Mullerian agenesis and androgen insensitivity syndrome? The investigation of choice to differentiate between them is karyotyping. Mullerian agenesis will be 46XX and androgen insensitivity syndrome will be 46XY, right? Now look at your question. Your question said that a 16-year-old girl was brought to you with complaint of primary amenorrhea. On evaluation, axillary hair and pubic hair are present and other secondary sexual characteristics are normal. So in case of present pubic hair, axillary hair, secondary sexual characteristics, I am thinking about Mullerian agenesis, right? कि Mullerian agenesis में secondary sexual characteristics are normal. Mullerian agenesis में axillary hair present, Mullerian agenesis में pubic hair present, and also I can also think about cryptomenorrhea. In cryptomenorrhea also secondary sexual characteristics are present, and pubic hair will be present, axillary hair will be present. In androgen insensitivity syndrome, only secondary sexual characteristic will be present. Axillary hair and pubic hair will not be present, right? Let's read further. LH and FSH values are normal. Now, LH and FSH values normal means again I am ruling out androgen insensitivity syndrome, because in androgen insensitivity syndrome, LH levels are high, FSH is normal. Again, I am keeping these two things in my mind, Mullerian agenesis and cryptomenorrhea. Question further says there is absence of uterus. Now, because question is saying absence of uterus, so I am making the diagnosis as Mullerian agenesis, that is MRKH syndrome. What happens in Turner's syndrome and Swyer's syndrome? Please remember, in Turner's syndrome, which is 45XO. So, in case of Turner's syndrome, which is 45XO, in case of Swyer's syndrome, which is 46XY, in case of Kalman syndrome, which is 46XX. In all these three cases, secondary sexual characteristics will be absent. Number one, right? Number two, in all these three cases, FSH levels and LH levels will be high, right? So that is why this question is not of Turner's syndrome. It is not of Swyer's syndrome. Clear to all of you? So let's go to the next question. A 17-year-old female presents with primary amenorrhea, but she gets abdominal pain every month. On examinations, she has normal development of secondary sexual characteristic. There is an abdominal lump, and on parting the labia, a bluish bulge is noted. Just now we did this, right? As I told you that when you are going to do a local examination, in case of imperforate hymen, you are going to get a bluish bulging hymen. Number one, I told you because of hematometra, uterus will be bulky, so on per abdominal examination, you may get an abdominal lump, right? And her secondary sexual characteristics will be normal, and this patient is complaining of abdominal pain every month. So no doubt we are dealing with imperforate hymen. Considering the suspected diagnosis, what would be the management? What is the management? If there is imperforate hymen, the management is you have to give a cruciate incision on the hymen, an X-shaped incision on the hymen. Is that clear to all of you? Yes. So these were the questions which came in FMGE June 2021. I'm not doing all of them with you. Now, I also want to discuss with you a few questions which came in this year, that is January 2023. So FMG January 2023, recall a few important questions. I'm discussing them with you. Question number one, vacuum is contraindicated in all except option A, preterm delivery, option B, fetal distress, option C, cephalopelvic disproportion, option D, breech. Now, before I tell you the answer, you are going to tell me in which conditions is instrumental delivery contraindicated. Instrumental delivery includes vacuum and forceps both. So what are those conditions where you will not put either vacuum nor you are going to put forceps? Number one, if there is cephalopelvic disproportion. Instead of cephalopelvic disproportion, your question may say macrosomia. So whenever your question says CPD or macrosomia, you are not going to apply forceps, you are not going to apply vacuum. Number two is inadequate pelvis. Inadequate pelvis. Number 3 is if in the baby you are suspecting bony deformities like osteogenesis imperfecta, right? Or in the baby if you are suspecting coagulopathies. And number 5, if it is an HIV positive mother. So these are contraindications for applying both vacuum and forceps. This means that yes, in CPD, vacuum delivery is contraindicated. Please read your questions always very carefully and mark the key points. They have asked you vacuum is contraindicated in all except, right? So yes, in CPD, it is contraindicated because any kind of instrumental delivery is contraindicated. Now, what are the contraindications for vacuum specifically? Contraindications for vacuum delivery are number 1, preterm delivery. Right? In preterm delivery, only vacuum is contraindicated, not forceps. Number 2, face presentation. Number 3, after coming head of breech, in other words, breech presentation. Right? So in these conditions, vacuum is contraindicated. So preterm delivery, it is contraindicated. Breech, it is contraindicated. So the answer over here is fetal distress. Please remember, fetal distress is an indication for using forceps and vacuum. It is not a contraindication. The other thing which I want you to remember is that these days, whether it is vacuum or whether it is forceps, you have to apply them only and only if the station of fetal head is at +2 station or below it. In other words, +3, +4 or +5. So if your question says that station 0 may again vacuum and forceps contraindicated. These days we do not apply forceps or vacuum if station is above +2. We have to apply vacuum and forceps only if station is +2 or below that. Clear to all of you? Okay. Next question. Identify the type of placenta previa shown in the image. Now over here what you are seeing that the placenta, edge of the placenta is reaching the internal os. Placenta is not covering the internal os, but it is reaching up till the internal os. And when the placenta reaches up till the internal os, that is a type 2 placenta or a marginal placenta previa. So type 1 placenta previa means that the placenta is within 2 centimeters of the os. Right? So if placenta is within 2 centimeters of the os, but it is not reaching the os, then that is type 1 placenta previa, which is also called as lateral placenta previa. Then if placenta touches the internal os, the edge of the placenta touches the internal os, that is type 2 or marginal placenta previa. If placenta covers the internal os partially, that is incomplete or type 3 placenta previa. And if it covers it completely, then that is type 4 or complete placenta previa. Now this classification is the older classification and you have to remember it, but then you also have to know the newer classification for placenta previa. In the newer classification, there are only 2 categories, low-lying placenta and placenta previa. Remember, type 1, which was in the older classification, is now called as low-lying placenta previa, which means that the placenta is within 2 centimeters of the internal os, but it is not touching it. Type 2, type 3 and type 4 are now classified as placenta previa. So in the newer classification, we have low-lying placenta and we have placenta previa. Type 1 of the older classification comes under low-lying placenta, type 2, type 3 and type 4 comes under placenta previa, right? So over here the answer was, it was reaching up till the margins of the internal os. So it is marginal placenta previa or type 2 placenta previa, right? Then Question number 3. A female complains of thin frothy discharge. On examination, her vagina is red. On saline microscopy, motility is seen. The diagnosis is so many keywords which are telling you the diagnosis. So number 1, patient has come to you with thin frothy discharge. In my app, in the video, I have told you that whenever you get this word frothy discharge, even if they have not mentioned the color as greenish yellow, frothy discharge points towards trichomonas, right? In trichomonas, the discharge will be foul smelling. It will be yellowish green in color, right? Number 2, on examination, in case of trichomonas, you get a red vagina, that is strawberry vagina or angry looking vagina. Then all of you know that the investigation of choice in vaginitis is saline microscopy, right? And what do you get in saline microscopy on trichomonas? See, trichomoniasis, it is due to the protozoa trichomonas, and trichomonas is a flagellated protozoa. So when you will do saline microscopy, you will see something moving. In other words, motility will be present. So that means we are dealing with the case of trichomoniasis. Remember, trichomonas is a sexually transmitted disease. The pH of discharge in case of trichomonas will be more than 4.5. Because it is sexually transmitted, that is why partner treatment is mandatory. In case of trichomonas, patient will definitely come to you with complaint of pruritus. Then the drug of choice to treat trichomonas infection is metronidazole, right? Now, what do you get in case of bacterial vaginosis? In case of bacterial vaginosis, your question is going to say that there is grayish white discharge. Grayish white discharge. This discharge will have a foul smelling odor, right? There won't be any pruritus. There is no pruritus. This is due to alteration in vaginal flora, right? Then when you are going to do saline microscopy, you are going to get clue cells. What are clue cells? Clue cells are vaginal epithelial cells to which the bacteria are adhered. So you will see vaginal epithelial cells to which the bacteria are adhered, and clue cells will be more than equal to 20%, right? Then in case of bacterial vaginosis, the pH of the discharge again is more than 4.5. This is not a sexually transmitted disease, and the diagnostic criteria for bacterial vaginosis is called as Amsel's criteria. Amsel's criteria. When you put potassium hydroxide in the discharge, you get a foul smelling odor. This is what is called as whiff test positive. So whenever your question says whiff test positive, it means they are talking about bacterial vaginosis. So the drug of choice for bacterial vaginosis is also metronidazole, and please remember, partner treatment is not done because it is not sexually transmitted. If your question is coming on candidiasis, your question is going to say that the patient's main complaint in candidiasis is pruritus. You know, she's not much worried about the discharge, but she is more bothered by pruritus or itching. There will be a curdy white discharge, and this discharge usually is scanty. Right? This is the only case where pH of the discharge will be less than 4.5, right? And on saline microscopy, you are going to see the fungal hyphae. fungal hyphae. Please remember, candidiasis is the most common vaginitis to be seen in pregnant female, to be seen in females who are using steroids for a very long time, in females who are using OCPs or the ones who are using antibiotics, or in immunocompromised females, right? What is the drug of choice for candidiasis? The drug of choice for candidiasis is fluconazole. Again, in candidiasis, you do not give the partner treatment unless and until partner is symptomatic. Right? In trichomonas, you have to give the partner treatment. In bacterial vaginosis, you never give partner treatment. In candidiasis, you have to give partner treatment only if the partner is symptomatic. Right? Otherwise, we don't give partner treatment. Now comes, what about the physiological discharge leukorrhea? Leukorrhea. Right? This is the normal white discharge which a female has throughout her menstrual cycle. Some females have more, some females have less. Now, in leukorrhea, again, the color of the discharge will be white, number one. Number two, the important point is there will be no pruritus. Patient will never have itching because of that discharge. Number three, it is not foul smelling, and that is how you can differentiate it from bacterial vaginosis. In bacterial vaginosis, again, it is grayish white in color, no pruritus, but then it has a foul smelling odor. Here, it will not be foul smelling. Leukorrhea can be scanty or it can be profuse. That depends on the time of menstrual cycle when it is happening. If it is happening in the first half of the cycle, it will be profuse. If it is happening in the second half of the cycle, it will be scanty. So based on scanty or profuse, we do not make the diagnosis. We make the diagnosis based on the characteristic of the discharge, that it is white in color, no pruritus, and not foul odor. So if these three things come, then you are going to make the diagnosis of leukorrhea. Clear to all of you? Yes. So I hope this session was useful to all of you, and I hope all of you are going to make best use of this feature which is there on the Marrow app, that is the previous year questions. I don't need to tell you the importance of previous year questions, because all of you know that it's not the previous year question which is important. The topic from where the question comes is also very important, and as you can see in the app, when you go, there is a detailed explanation for that question. So just don't mug up the right answer. Read the explanation, understand that why this is the correct answer, and read all the relevant important points related to that particular topic, right? Now, before I end this session, as I had promised to you, I am going to share with you the most important topics in OBS for FMG, but that doesn't mean that you are not going to study the other topics, right? You have to focus on these topics, but you have to read everything in OBS and Gynae, because that's a very, very scoring subject, right? So, and in OBS, antenatal care, maternal adaptations, PIH, diabetes, antepartum hemorrhage, abortion, ectopic, molar pregnancy. Generally, they give you one question from this, from bleeding in early pregnancy. Then these days, they have started giving you questions from third stage complications. So you may get a question on PPH, perineal tear, uterine inversion, or amniotic fluid embolism. Procedures like versions, episiotomy, cesarean section. In cesarean section, classical cesarean section and VBAC, that is vaginal birth after cesarean section, is very important. Then instrumental delivery. They have started asking questions on instrumental delivery, so that becomes very important. Puerperium is very important for you. Then occipito-posterior at breech presentation, active management of third stage of labor, and cord prolapse. These are some of the very important topics which you cannot afford to miss out for your upcoming FMG exam. Similarly, important topics in gynae are cancer cervix, including your screening for cancer cervix, that is everything related to pap smear, everything related to WHO's new screening methodologies, everything related to HPV vaccine and CIN. When I say cancer cervix, all this. Then cancer vulva, management of cancer vulva, and in brief, You know what is the most common vulval cancer, what is the most common symptom of vulval cancer, that is important. Staging for vulval cancer is not important for you. Then cancer ovary. In cancer ovary, again, you can let go the staging of cancer ovary, but other than that, everything about cancer ovary is important. Then in atypical uterine bleeding, I want you to be specific on postcoital bleeding. They ask you specifically questions on postcoital bleeding, postmenopausal bleeding, and endometrial hyperplasias. PCOS is very important. Contraception, everything on contraception is important. Management of fibroid, management of prolapse, management of endometriosis is important. Primary and secondary amenorrhea, which includes your disorders of sexual development, right? Then congenital malformations, because they will ask you congenital malformations in the form of image-based questions. And then vaginitis and PID. These are the most important topics which you have to know for your upcoming FMG exam in gynae. So all the best for your exam. Keep studying. Take care. Bye.